Welcome to the Council of State Governments webinar series. Today's webcast is entitled Needle-borne Disease and Substance Abuse. My name is Deborah Miller. I'm the Director of Health Policy at the CSG National Headquarters in Lexington, Kentucky. Today we will be discussing Indiana's recent HIV epidemic that was traced back to prescription opioid drug abuse, how the state policymakers reacted, and the latest research on the most effective strategies to treat drug abuse and addiction. The timeliness of our topic was reinforced yesterday when President Obama announced a $13.4 million initiative to address public health and public safety concerns related to drug abuse. I'd like to go over a couple of webinar housekeeping details. Those of you who have called in will be in a listen-only mode. We do ask that you type in any questions you have of our speakers in the go-to meeting box that should appear on the side of your screen, and we'll get to as many of those questions as we have time for. The audio and the slides will be posted on our CSG Knowledge Center, www.csg.org/KC for Knowledge Center. And you will get a notice of that posting when we get it up, and we invite you to share that with your colleagues. Our first speaker, I'm very pleased to introduce to you Representative Ed Clear from Indiana. He chairs the Public Health Committee there in Indiana and has been a legislator now for 4 terms. He's a real estate agent and is active on several community boards and a youth soccer coach and parent of, I believe it's 5 children. He's been very active with CSG on the regional and national levels and currently serves as the co-chair of CSG's Health Public Policy Committee. He will introduce today's speakers as well as provide us an update on the policies adopted in Indiana in the fight against the recent AIDS epidemic in the southern part of that state. Representative Clear, I'll turn the webcast over to you now.
Thanks, Deborah. Welcome to everyone who's on the call. Thank you for joining us today, and thank you to our panelists for making yourselves available to talk about this very timely and important topic. It's my pleasure to introduce Maureen Hayden. Maureen's going to provide us with her perspective as a journalist. She is the State House reporter in Indiana for CNHI, which owns 13 newspapers in communities throughout Indiana. And Maureen, I've had the privilege of knowing Maureen for a number of years, and she was the first reporter who took a real interest in the syringe exchange issue, and I'll talk more about that after Maureen's remarks and her slides. But she was the first reporter to cover it and did quite a bit of coverage, and I think really did a great job informing her readers and the public at large, and also elevating the issue during the legislative session. So with that, Maureen, please go ahead.
Thank you. Thank you, Representative Clear. I appreciate the introduction. As Representative Clear said, I write for a large group of newspapers here in Indiana, and many of them are in smaller communities. And so I think that is why this story probably captured my attention and the attention of my editors and their readers. As you now know, as we now know what happened here in Indiana, this past year, we had the largest HIV/AIDS outbreak in rural America that unfolded right here in southern Indiana. I'm just going to run through really a brief timeline and not try to take up too much time, because we can always ask for more questions, and there's now a great deal of information online that you can go to find out more about what happened here. But briefly, it helps to know that this was indeed an HIV epidemic in rural Indiana, which is critical because, as you know, we've thought of HIV and AIDS as something that is a disease among gay men in big cities. and for it to occur in a small community, a small, poor, rural community among IV drug users, heterosexual IV drug users, was startling and helps explain in part why I think many people were unprepared for how fast this erupted and how to respond. So you know the epicenter of the epidemic is really a small town in Austin, which is about 4,200 people in a small community in southeast Indiana, nestled right off of Interstate 65, which is our main north-south drag that goes from the northern United States all the way down to the southern United States. For us, it's the road between Indianapolis and Louisville. It's a very small town. It's in Scott County, which has, over the last few years, ranked the worst county in terms of health indicators here in Indiana. Let's move on to the next slide, because you'll see what happens is in February of 2015, we see a press release sent out to us in the media. State health officials are announcing what they call a quickly spreading outbreak of HIV in the southeast portion of the state, and they indicate that there have been 26 confirmed cases and 4 preliminary cases at that point that they had found. So you know, I don't want to jump ahead, but we've got over 170 cases now. I put this up here because this is February, but really it had begun to unfold before February. In November of late last year, in November, a Scott County Health Department public health nurse saw that there were 3 newly diagnosed HIV patients in her community, which that in itself was an indicator to her of some concern, since there had only been 3 cases of HIV in the past 6 years in her community. She interviewed those folks, one in an outpatient clinic, one in an area hospital, and one in a drug rehab program. 2 talked about recently injecting drugs and sharing contaminated needles with each other, and also talked about having a range of sexual partners. Here in Indiana, we did not, until this point, have a needle exchange program, so it was common for IV drug users to be sharing their needles. So if you can pop ahead to the next slide. I put this up here. This is a story from 2012 in USA Today, and I put this up here because when we saw that slide that I just showed you, that press release, we were surprised. I was startled actually to see an outbreak of HIV in a rural community here in Indiana among IV drug users, but I shouldn't have been surprised, and other folks who indicate that they were surprised shouldn't have been either if we had been paying attention. This story in USA Today that ran back in 2012, as you'll see, there's a picture of a guy holding up a drugstore. He's not demanding money in this picture, that robber. He's demanding drugs. He's holding up a drugstore in Fort Wayne, Indiana, and demanding that the clerk hand over opiate drugs, which is probably not a surprise to you. This is a crisis happening across the United States, but certainly in the Midwest, where we had a huge number of prescription IV drugs that were being prescribed for initially legitimate purposes, and then people got hooked very quickly on them, as you know. Here in Indiana, we try to contain that, roll back some of our prescription drug policies, and that really led to even more of a crisis in terms of opiate addiction and demands from people to get their opiate drugs from illegal sources because they couldn't get it from their doctors anymore. If you go on to the next slide, you'll see by March 20th, so again, we get the first indication, we in the media get the first indication in February, but by March 20th, I've got a story here that I wrote about the HIV outbreak continues to worsen. So from February, when there were 20-something cases, by March 20th, there are 55 cases. And you'll see in this story, we talked to the Clark County public health officer. He oversees the Scott County program. Scott County is such a small rural community that they didn't even do HIV testing until this crisis erupted. Here in Indiana, like in many rural states, you had to go someplace. You know, there wasn't a lot of easy access to HIV testing in rural areas. In fact, out of our 92 counties, only 26 of our county health departments offered HIV testing. So other folks had to step in, and in this case, the Clark County public health officer in a neighboring county stepped in to help oversee the crisis and the response to the crisis. The words that he used in this story were alarming to me. He called it a crisis. If your eyes can move ahead a few paragraphs, he talks about this as a crisis. Intravenous drug users and prostitutes who are engaging in this very risky behavior of sharing contaminated needles and having sex, unprotected sex. What he says next to me is this kind of cluster of cases in a small county is extraordinary. We could be looking at HIV levels akin to sub-Saharan Africa. I mean, that's alarming. Absolutely, that's alarming language for those of us here in southern Indiana who never expected anything like this to break out. The next slide. One of the things that struck me about this story and why I wanted to throw it out here is just, again, this sense of alarm that we had here, and this sense of increasing understanding that this really is a drug crisis. You'll see in that quote at the top of the slide, we should have had a handle on a lot of this stuff for a long time. We've let this community run wild. And that's from a city councilman there in this small town of Austin. I don't think folks really had a sense that they were intentionally letting people run wild. But that picture you see of the syringe in grass there, that wasn't a setup. That was, the photographer, one of the photographers I worked with, went down to this community to take some pictures for these continuing stories were written, and he said it was not unusual at all to find these dirty syringes just laying on the sidewalk. And again, an alarming indicator that this community was in trouble and in increasing trouble. On the next slide, why I included this is you'll see that the numbers just continue to grow. By the end of March, these numbers were doubling, close to tripling in this small community of Austin, Indiana. The Centers for Disease Control at this point have stepped in. They're alarmed at the incredibly fast rate of HIV among IV drug users. They're also alarmed at this point at the location of this community. It's right along Interstate 65, close to truck stops and rest areas. And the folks in Scott County at the Public Health Department there know that there are women who are infected, HIV infected, and yet they're continuing to engage in risky, unprotected sex at these truck stops and rest areas because they need the drugs. They're still drug addicts, and they're engaging this kind of behavior because they need the money to support their habit. So the CDC becomes increasingly alarmed that maybe this is going to be something, a disease that's going to spread beyond Little Austin, and we're going to start to see it in truck drivers up and down Interstate 65. The other key thing here is that the crisis levels had reached a point where our governor declared a health emergency. And what that helped to do was, and Representative Clear will talk about this, I know, it just triggered a lot of resources being devoted to Austin and to Scott County. It just opened the door for many, many resources to go rushing down into this community. It did indeed open the door for a needle exchange, which Representative Clear will talk about. But the other fascinating thing to me about this was, again, thinking of this as a poor rural community. Many of these people didn't have health insurance, they didn't have any health coverage, and so one of the things that the state did was to send folks down to get them signed up for the state version of the expanded Medicaid program. Indiana now is indeed part of that program. But to sign those folks up, they needed people to have basic IDs, a driver's license, a birth certificate, some form of identity that they could use to help you sign up for insurance. And a lot of these folks didn't even have that. They couldn't find a birth certificate. They couldn't pull themselves together enough to get to the neighboring community, to the local health department there to find to get to the vital statistics office. So one of the things that our state health department did was send people down from the Bureau of Motor Vehicles and from the Vital Statistics Office in the State Health Department, who did nothing but help people get a hold of their birth certificates or get state-issued IDs or driver's licenses. So we'll move on to the next slide. You know, I include this because we, again, as the number of cases grow, so this is March again, late March. Remember our early slide in February indicated there were 20-something cases. There are now 79 cases, and we know that that number is going to continue to grow. This is it's a public health emergency, but it becomes a political emergency as well. Here in Indiana, we do not allow for a clean needle exchange program. And so our governor, who has been a long time and vocal opponent of needle exchange programs, he served 6 terms in Congress. This was an issue that he had to deal with as a congressman. He had long opposed needle exchange, didn't think that it was good drug policy, you know, had some concerns about this very notion of handing clean needles over to drug users. But he found himself in a situation where he was forced to confront a public health emergency, and that's much different than when something is abstract or ideology. And so he found himself having to do some things that he probably had never anticipated having to do, including giving up setting aside this longtime opposition to needle exchange and trying to figure out how to respond to what was clearly a public health crisis. This next slide, I threw this in here because this is also late March of this year, and you'll see this is a New York Times article, and I don't know if you will recognize this headline or at least the theme of this story, because here's what we are also dealing with. So here in Indiana, our part-time legislators who are supposed to be done with their business by the end of April, there's this other issue that just had consumed our legislators. It was just sucking the oxygen out of the State House, was this a very difficult and divisive fight over a state law, a State Religious Freedom Restoration Act law, which supporters saw as preventing people's religious beliefs from being trampled upon, but critics, as you know, were concerned that it was just a license to discriminate. No matter how you feel about it one way or the other, the reality is it just was absolutely consuming our legislature, and that was the headline in the New York Times about Indiana, was this fight over this law that people thought was going to be a license to discriminate against gays. That's really where a lot of attention was going by late March. On the next slide, you'll see that doesn't last long. Indiana becomes the focus of national attention. Here is the Wall Street Journal story then on what's happening here in Indiana, this drug-related HIV outbreak, which is sparking this emergency here in Indiana. And you'll see in the subhead, the CDC did indeed, the Centers for Disease Control, sent their forces here as well to help our folks deal with this crisis. If this had been San Francisco or New York City or Detroit, I don't, you know, I'm sure CDC would have been interested, but not with the intensity, I think, that they came in here. I mean, they sent a pretty serious force of people in here, both to advise our health policymakers on what to do next, and also just to help literally track down people who may have been exposed to HIV. That in itself is very challenging, as you can imagine. The drug users may be a tight-knit group of people, but they're not sharing clear identifying information with each other. And it wasn't uncommon for a public health nurse to encounter somebody who had just tested positive for HIV who didn't know the name of the person that they had sex with a week before, or didn't know the names of the people that they had just injected drugs with and shared a contaminated needle with before. So those were the kinds of challenges, again, that our public health folks were facing, and increasingly were becoming part of a national story about the crisis of IV drug use and HIV/AIDS in rural America. This next slide, I'll just take you through a few more and turn it back over to Ed then. I put this in here because of, you'll see this interesting chart shows both HIV, new cases of HIV, but the chart below it is interesting as well, So back in 2012, which is what this chart is from, Indiana did not have high rates of HIV. We were among the lowest states, as you can tell. But what was going on, if you look at the map below, is we were seeing increasing numbers of hepatitis C, which, as you may know, is a lethal blood-borne disease, also spread often by IV drug use and unprotected sex, and it also often accompanies HIV. So it's a warning signal. It should be a warning signal to states, to communities, that if they've got high hepatitis C rates, that means they've got a lot of risky behavior going on, and HIV may not be too far behind. A whole other conversation that I don't think we have time for today, but is interesting to look at, is hepatitis C, as you may know, is a very expensive disease to treat. It's at about, I think the current protocol of a series of treatments, maybe $80,000, $90,000 a person. The folks who were infected in Austin and Scott County were Medicaid patients. They didn't have private health insurance. The state is bearing the cost of this, both in terms of HIV and hepatitis C. As a very quick aside, one of the challenges here in Indiana in terms of treating hepatitis C is that we have doctors down in Scott County who can treat those patients who are infected with HIV, but they cannot treat those very same patients who may also be infected with hepatitis C. Our Medicaid rules are very strict in terms of who can prescribe treatment for hepatitis C, and it currently limits it only to doctors who are infectious disease specialists or gastroenterologists, neither of which exist in very many communities in rural Indiana, and certainly not in Scott County. So that presents another challenge of folks who are being treated for HIV down there in Austin and Scott County, who are having to travel an hour or so away to find a specialist to treat them for hepatitis C. On this next slide, just a few more, really. I threw this in for two reasons. One, because I thought it was fascinating that the Indiana Economic Digest decides to pick up this story. It's beyond a public health story. It's beyond a political story. It really is becoming it has economic impact when you have these kinds of crises occur in communities and in the state. I highlighted a paragraph in that story to indicate that we're a conservative state here in Indiana. We are going to be reluctant about making dramatic changes in our public health policies. But among those who really advocated strongly for the Needle-exchange program was, as you'll see in the story I highlighted, Senator Jim Smith, who's a conservative Republican whose district includes Scott County. Senator Smith said to me he never, ever would have expected that he would have been advocating to give clean needles to drug users. But when these kinds of situations erupt in your communities among people people whose family members that you're friends with who are in crisis, you respond differently. So let me wrap up with just a handful more. This next slide, I pulled this in there because it's The Guardian. The story now is The Guardian is a British newspaper. It's now a sweet little community in Indiana has now become a national and international story. And that's the sign you see when you go to Austin, Indiana, or you did for quite some time, was where to go to get, to exchange your dirty needles for your clean needles. One quick story from right around this time, I remember reaching out to one of the doctors in Scott County to ask what kind of help he needed and what kind of help he was being offered. And he said really one of the best offers of help came from a local church who called him and said, "What can we do for you?" And he said, "You could send in some folks to help clean up the trash, to help me pick up these dirty needles that are being strewn around this community." And he met this local church group and got them the gloves and other protective equipment that they needed, and did a little training on what to do when you come across a needle. And he said that that was one of the most impactful things, is having a group of local folks from a church help him clean up the streets of his little small town. On this next slide, you'll see now this is May. We're still in the news. Remember, the outbreak is first found by a local public health nurse in November, and it reported to us in the media by February, and by May we're still a national story. And indeed, this headline is accurate. Rural Indiana struggles to contend with an HIV outbreak. It was a struggle in a small community where people just were not prepared for this kind of crisis. And as you know, the numbers do continue to grow as we go. I had mentioned earlier that we're up to over 170 cases. This next slide I put in there because it's interesting, again, it becomes not just a public health story, but a political story as well. This is from Politico magazine, a fascinating story really about HIV erupting in rural America and in these conservative states, conservative red states that have not had the kind of experience that other places have had with HIV and AIDS. Again, what lawmakers may have done in San Francisco, in Chicago, in places where they're big cities where they've been wrestling with HIV for a number of years, they knew what to do simply because they were forced to have gone through these experiences. And then on the next slide, I'll wrap up with a strong recommendation to folks that they read this Time magazine story, although I think by now many of us already know this story, which is the story of Scott County and of Austin, Indiana, and IV drug use is really a bigger story of prescription painkillers and how prevalent they were, how easy it was to get access to them at one time legally, how quickly people became addicted to them, how states then tried to rein in those prescription drug numbers by cutting back or increasing the restrictions on doctors who could prescribe drugs. In the meantime, you had lots and lots of addicted people who were pretty desperate to feed their addictions. So with that, I'll wrap up, and I thank you for the opportunity to talk to you about this.
Thanks, Maureen. I'm going to make a few brief comments, and I want to allow time for Courtney and also time for questions. So Maureen covered a lot of ground there and did a great job. I want to go back and touch on a few things, just a few observations. First of all, the HIV outbreak highlighted a number of things, two things in particular. One, our opioid problem in Indiana, which is being experienced in similar fashion throughout the country. But we have the Scott County situation involved the injection use of Opana, and there was a lot of focus on that, but it just as easily could have been heroin or another drug, another injection drug, and we see a heroin epidemic throughout the state of Indiana. And then the other thing that the HIV outbreak highlighted was just our existing lack of public health infrastructure, especially in rural areas, but really everywhere in Indiana, to a greater or lesser extent, especially in rural areas, but throughout the state. The legislation on syringe exchange was obviously a response to the HIV outbreak. We had a piece of legislation last year in the 2014 session that we passed out of the House, and it died in the Senate for lack of a committee hearing, and it would have simply allowed for study of needle exchange, for legislative study of the issue. And to illustrate how far we came in a year earlier, we couldn't even pass a bill allowing for study of needle exchange, and a year later we're actually doing syringe exchange. So it was quite a transformation. It was probably the most difficult issue and the most difficult piece of legislation that I've worked on. I've been in the House for 7 years now. I've been the chairman of the House Public Health Committee for 3, and it was just a very difficult issue and difficult piece of legislation, and I'll be happy to talk more about that when we open it up to questions. We had the announcement from the state health department about the existence of the HIV outbreak in February. I believe it was February 25th, and we were already almost exactly halfway through our legislative session at that point, and it was too late to introduce new bills. So I offered the syringe exchange language as an amendment to a state health department bill that had already passed the Senate and was in the House awaiting the hearing. So the announcement of the outbreak was February 25th. We had a 3-hour committee hearing on the proposed amendment to the health department bill on March 25th, exactly a month after the outbreak was announced. And then the legislation underwent a lot of changes and ultimately passed on the last night of the session, which was April 29th. I think it was the 4th or 5th to last bill of the session to pass, just maybe an hour or so before the state budget. So it came down to the wire. And in short, the legislation allows for syringe exchange on a county-by-county basis. It has to be initiated locally and then approved by the state. So basically, the county health officer has to find 3 things. 1, that there's an epidemic of either HIV or hepatitis C. 2, that the primary mode of transmission is IV drug use. And then 3, that syringe exchange is medically appropriate as part of a comprehensive response to the epidemic. And I think one of the critical points with legislation was the inclusion of hepatitis C as a basis for syringe exchange, because hepatitis C is an indicator of HIV risk, and even though many of us would have gone further or been more expansive in allowing syringe exchange, at least with Hep C, we don't have to wait for an HIV outbreak or epidemic before we can do syringe exchange. So the health officer has to find those things to be present, and then there has to be a public hearing with the county commissioners in the case of a county, or with the council in the case of a municipality, and they have to request permission for syringe exchange from the state health commissioner, who, if he or she finds that everything is in order, then will declare a public health emergency in that county, and that will allow syringe exchange for a period of up to 1 year. So one of the questions we can talk more about is what happens after a year when that authorization goes away. And you know, I think Maureen touched on this, but the kind of the underlying tension as we worked on this was between anti-drug policy and harm reduction policy, and suffice it to say, many legislators were very reluctant to support syringe exchange, even in light of the Scott County crisis. Certainly without the Scott County crisis, this legislation would not have passed, but there was a reluctance even with the crisis. And I think it's going to be part of an ongoing discussion probably for some time to come. And with that, I want to leave, again, plenty of time for Courtney and also for questions. So I'll be happy to answer any questions when we get to that point in the call. I apologize for rushing through that. But in addition to Maureen, we're also fortunate to have on the line with us today Courtney Cunningham, who is Program Director of the New England Comparative Effectiveness Public Advisory Council, or CEPAC. Courtney is responsible for the strategic planning and execution of one of the Institute for Clinical and Economic Review's core programs, which is CEPAC. Prior to joining the Institute, Courtney worked as a research analyst for the Massachusetts Association of Health Plans. She was previously a senior clinical research coordinator and has served on research teams in the United States and internationally. So with that, Courtney, why don't you go ahead and launch into your presentation.
Thank you, Representative Clear. I appreciate the introduction. Not included in that introduction, and by way of background, I was a community health worker in a rural community health center in Lowell, Massachusetts at the very beginning of my career. And that was a time when we were hearing in that area about the opioid epidemic before it was hitting the rural communities in Massachusetts. So as I have continued my career, this epidemic has followed me, as I'm sure many others are experiencing as well. So by way of background, we'll go to the next slide. The Institute for Clinical and Economic Review is a nonprofit research organization based in Boston. We work to examine the evidence on the value of medical tests, medical treatments, and healthcare delivery system innovations. Our goal at ICERI is to move our evidence into action to improve patient care and control costs. CEPAC is an independent body. CEPAC is composed of physicians, health economists, and both patient and public members. CEPAC convenes publicly to deliberate and assess comparative clinical effectiveness and value of a range of healthcare interventions and provides recommendations for how evidence can be best applied to policy and practice. CEPAC and ICERI works directly with a range of stakeholders, including Medicaid programs, regional private payers, and provider organizations to identify topics for each of our CEPAC meetings. Throughout this public process, opioid dependence consistently came up as a major priority for all of our stakeholders. Next slide. As many of you have experienced in your home states, we are experiencing that nationwide opioid dependence has reached a critical level in the United States. The epidemic has been largely driven by overprescribing and diversion of opioid painkillers, as well as the low cost and increased potency of heroin. The societal impacts of this growing tide of opioid dependence is substantial in terms of costs related to treatment, lost work productivity, criminal activity, and social welfare expenditure. In a recent publication, the Substance Abuse and Mental Health Services Administration, or SAMHSA, reported that 4 out of 5 heroin users started using prescription drugs first. Individuals addicted to opioid painkillers are 40 times more likely to also be addicted to heroin. Next slide. Our first step in developing an understanding of the opioid crisis and options for treatment was to review the existing evidence. Next slide. Given the broad scope of this topic, ICERI built off of several prior systematic randomized control trials and then supplemented with additional randomized control trials, comparative cohort studies, and case studies that were published between 2003 and 2014. We examined specific treatment outcomes, including the use of illicit opioids and other drugs, relapse, mortality, employment, criminal activity, and health-related quality of life. The goals of treatment for opioid dependence include decreasing illicit opioid use, reducing mortality, and diminishing criminal activity. It's important for everyone to recognize that the options for opioid addiction treatment are very different than those for other addictions. There are currently no FDA-approved medications to treat addiction to cannabis, cocaine, or methamphetamine, but there are options for treating opioid addiction. The pharmacological treatment options for opioid addiction include methadone, buprenorphine and naltrexone together commercially as Suboxone, and naltrexone by itself, known commercially as Rivia and Vivitrol. Next slide. ICERI's first major comparison of interest was to examine strategies that use long-term medication maintenance against strategies that use detox. A detox program is any treatment program with opioid abstinence as the goal that is less than 30 days in duration. Medication-assisted maintenance treatment programs are those that treat opioid addiction using a medication, for example, methadone, buprenorphine, or naltrexone, for a longer period of time. Next slide. When we reviewed the existing data, we found that all of the available systematic reviews and studies consistently showed the same thing. Medication-assisted maintenance treatment is superior to detox and all other short-term strategies for stopping all opioid use. Medication-assisted maintenance works better than detox both in terms of retention and treatment, as well as reducing the overall use of opioids like heroin. It's important to note that even in treatment arms that utilize the medication-assisted maintenance, the relapse rate was approximately 50%, but that's compared to 74% relapse rate in the detox arm. About 67% of those that received maintenance treatment stayed in the program, while only 45% of those that received detox remained in programs. Next slide. Since we established that maintenance is more effective than detox, we also wanted to look at the different agents that were used. First, we looked at methadone and Suboxone. As I mentioned, Suboxone is a combination of buprenorphine and naloxone. Methadone and Suboxone appear to be comparatively effective. The evidence here demonstrates that they have similar effectiveness with no statistically significant differences between them in mortality, effects on criminal activity, or continued illicit drug use. The only real significant difference between them was there was somewhat better treatment retention in methadone. In the U.S., this is likely correlated with a greater regulation and treatment oversight of methadone clinics versus the office-based Suboxone prescribing. Next. We also looked at the evidence surrounding naltrexone because a lot of policymakers have expressed interest in how it works. Naltrexone is not an opioid replacement therapy. Rather, it works to block cravings in patients who have stopped using opioids. Naltrexone has been implemented in prison settings among populations that have stopped using opioids while incarcerated. In looking at the evidence, the available clinical trials of oral naltrexone suggest it's no better than the placebo at keeping patients in treatment or controlling illicit drug use. However, the data on the injectable naltrexone, or Vivitrol, suggests better compliance. The evidence in this space is still pretty limited and has been identified as an area where future research is needed. Next. Many of the stakeholders and policymakers that we touched base with were interested in understanding if there's a certain subset of patients that may be able to taper maintenance medication to achieve opioid abstinence. At ICERI, we found that in general, attempts to taper maintenance medication to complete abstinence have been largely unsuccessful. There are some more recent observational studies that suggest a longer duration taper for more than 3 months may have a better chance of success than shorter tapers. The data also shows that there's a meaningful subset of patients who might benefit from tapering and other detox strategies. These patients are unlike the other subset of patients in that they have had a relatively short duration of addiction, they have not used injection drugs, they are usually employed or well-educated, and have good support systems at home. So in summary, the evidence demonstrates that maintenance therapy is more effective than detox-based approaches, or those that focus on opioid abstinence as an ultimate goal. So we know these treatments work, and next we wanted to find out if they have value. Next slide. In addition to an evidence review, ICERI conducted an economic evaluation. Next slide. ICERI built a 2-year budget impact model to assess how much Medicaid programs in New England would spend if they expanded access to methadone or Suboxone. We use New England-based numbers for this model because we were working with stakeholders from this region for our project. When just looking at healthcare costs alone, we found that the additional cost of moving untreated individuals into a maintenance treatment program are fully offset by savings and cost of other healthcare services that these individuals would have incurred if they had not received medication-assisted maintenance treatment. The opportunities for savings are even more significant when you consider societal costs in addition to healthcare costs. Societal costs include things such as criminal activity, recidivism, incarceration, and employment. So at baseline, using regional data, we estimated that New England is currently spending approximately $29 billion every 2 years on its opioid-dependent population. Of that $29 billion, about 81% of those costs are being generated by individuals who are not currently receiving any treatment at all. So in our estimate, we looked at cost-shifting individuals that are currently not receiving treatment into treatment. We did a few different types of estimates, and that's what you'll see on your screen. We estimated the cost of shifting individuals that were currently not receiving any treatment to methadone or Suboxone treatment, and if the region took a modest approach and provided treatment to only 5% of those not currently receiving treatment, the total cost for the entire population of opioid-addicted individuals would decrease by $220 million. If 50% of individuals that are currently not receiving any treatment at all were put on methadone or Suboxone, the region could save as much as $2.6 billion in 2 years. So in short, every dollar that New England spends on expanding access to treatment would result in $1.80 in savings. Next slide. So here we have a treatment that works. We know it represents high value, but patients are still not using it. Next slide. We found that this is due to a number of barriers in the existing treatment landscape and the existing policy landscape. Access is limited in part because of a federal regulation that limits the number of patients that can be treated at one time with buprenorphine-containing agents. This legislation is known as Data 2000. The legislation made opioid addiction treatment agents available, but it set limits on their use. In order to prescribe a buprenorphine-containing agent, physicians must obtain a separate license and can only treat 30 patients at once with this medication. There is an option for physicians to increase their limit to 100 patients, but they have to apply for a second waiver to do so. Recent DEA data demonstrates that only about 1/3 of physicians who have the first level waiver go on to apply for the additional waiver. Next slide. Specific to methadone, in order to receive methadone treatment, a patient must go to a designated clinic to receive their medication. Take-home privileges can be granted, but for the most part, you take the medication at the clinic. In order to be admitted to a methadone clinic, patients must show that they have been addicted to opioids for a year. There are also long wait lists at most facilities. One of the largest sources of referrals for Suboxone or methadone programs come from those leaving correctional facility settings. However, unfortunately, these treatments are not available in most correctional facilities. Only 10% of individuals that could benefit from medication-assisted maintenance treatment receive it as part of their justice system supervision. Next slide. On this slide, you will see a treatment map of Indiana. For our report, we developed treatment maps for each of the New England states. But each state that we develop maps for in New England looks very similar to the map on your screen. Medication-assisted treatment is limited in many pockets of the state. The blue dots on this map are Suboxone providers. The red dots are methadone clinics. The yellow dots are naltrexone providers. Similar to what we found in other states, in Indiana, more densely populated areas have more treatment options. Unfortunately, in many parts of the state, there are a limited number of providers. Existing providers may not be accepting new patients, and many patients have to drive long distances to access treatment. Next slide. So to bring it back around, as I mentioned earlier, CEPAC is comprised of independent clinicians, scientific review experts, and public members from New England states. CEPAC members vote on the comparative clinical effectiveness and value of a range of health interventions. When CEPAC was voting on the results of this evidence review, they determined that medication-assisted maintenance therapy with any medication has superior effectiveness to short-term detoxification-based approaches. They also determined that medication-assisted maintenance therapy has high comparative value. They also voted that expanding access to maintenance therapy has high comparative value to the status quo. So this value judgment adopts a Medicaid perspective and includes both societal and direct healthcare costs. Next slide. So in addition to the evidence review and the economic model, CEPAC worked with stakeholders to come up with a set of policy recommendations intended to be utilized to expand access to maintenance treatment. The first policy recommendation focused on coordinated care efforts that are needed to improve access to opioid dependence treatment. The key mechanisms to help expand access are listed on your screen. Our first mechanism is that stakeholders highlighted the need to make changes to regulations that isolate methadone treatment from the rest of clinical care. Throughout our process, we talked with patients and other stakeholders, and we consistently heard that the highly regulated environment for methadone stigmatizes this treatment. Patients don't want to go to methadone clinics, and providers don't want to prescribe methadone and deliver it in the clinic. In other settings outside of the United States, there have been pilot studies looking at what happens when methadone is made available outside of office-based settings. These pilots have found that when methadone is offered outside of the office-based setting, there have not been significant issues with diversion or abuse. Our stakeholders also recommended establishing resources to support waivered physicians in increasing their capacity and willingness to serve more patients. This is related to the Data 2000 legislation that I discussed. So we consistently heard many physicians state that they lack the support and the necessary structure to manage the needs of complex substance abuse patients. Using systems for team-based care and providing addiction training as standard to medical education programs could help alleviate this. A third mechanism to expand access that came up in our discussion is relaxing the limits on the number of patients that can be treated by qualified clinical teams. Some have suggested that revising the federal policy to allow higher prescribing limits, specifically for highly skilled teams, may help the access issue. This has been subject of a number of legislative proposals, both in the state level and the federal level. Finally, stakeholders noted that it would be helpful to broaden the scope of the Data 2000 to allow qualified psychiatric nurse practitioners to prescribe buprenorphine-containing medications. There are some that feel that psych nurses can prescribe opioids for pain, and they should be able to prescribe opioid medications for maintenance treatment as well. Next slide. On this slide, you'll find an example of one of the ways that new technology can be utilized to help patients on waiting lists access some level of medication-assisted maintenance treatment. The picture you see is a MetaWheel. This is a device that's currently being studied in clinical trials in Vermont. It's intended to provide patients who are waiting for medication-assisted treatment at a methadone clinic with an opportunity to access some type of treatment. The device dispenses a single dose of buprenorphine for a limited 2-hour window each day, making it difficult for patients to abuse the medication. For patients who can't access treatment due to the availability of physicians or distance, this device would really help them to take Suboxone at home. Patients would receive care through regular telemedicine check-ins to manage cravings, provide relevant clinical care and follow-up, and make referrals to psychosocial services that are needed throughout their treatment. Because the device is built to be difficult to divert, it has the potential to make physicians more willing to prescribe using the device. This method of treatment is currently being studied and has the potential to expand access on a larger scale. Next slide. Second, we recommend that policymakers work to develop systems of care to to more effectively triage patients to the level of care that is appropriate for their individual needs. The current access problem exists due to a lack of providers to meet clinical need and inadequate systems for coordination of care. Care is siloed in our existing system. The type of care that a patient receives is dictated by the services found behind the door that they walk through when they are seeking treatment or are in crisis. The current system lacks a mechanism to match patients to the most appropriate care for their individual needs. Having a system of care with a more robust coordination mechanism would free up resources to treat more patients. In order to accomplish this, I recommend that policymakers consider fostering efforts that promote coordinated care networks in which patients receive short-term intensive outpatient care until stabilized and then are referred to lower levels of care for ongoing medication-assisted treatment in primary care settings or community-based practices. Next slide. Vermont is a perfect example of a statewide effort to create a system of coordinated care. Vermont's currently rolling out a model called Hub and Spoke. Hubs are specialized addiction treatment centers, predominantly methadone clinics, that provide intensive assessment and care coordination services for those experiencing complex addiction issues. Within the system, a patient would start at a hub until they are stabilized, usually for a short and intense period of treatment. Once they are stabilized, the patient would be referred to a spoke. Spokes are predominantly outpatient primary care centers that utilize team-based care with a prescribing physician that is licensed to provide ongoing maintenance treatment with Suboxone. If at any point the patient needs more intensive services, they can be referred back to a hub. Spokes are also connected to a broader community and web of psychosocial services and supports that a patient can benefit from to help facilitate referrals. The hub and spoke model has experienced challenges, but it shows a lot of promise. The biggest obstacle that Vermont has faced is getting physicians to agree to be spokes and getting the system to capacity. Next slide. Thank you for giving me the opportunity to present our findings today. As many of you know, opioid addiction is powerful and without boundaries. It's our hope that through robust research, informed dialogue, and thoughtful policy changes, we may be able to alter the trajectory of this harrowing epidemic.
All right, Courtney, thank you very much. Deborah, I know we're coming up on our 1 hour mark. Do we have time still for some questions?
I think we'll just leave it at this. We've only received 1 or 2 very specific questions, and I would encourage those people to go ahead and contact the speakers if they have a specific question. So I think we'll just let it go. And thank our participants so much. And thank you to Representative Clear for joining us today. And again, those of you who are listening in will get notice when we post this, and we urge you to share the posting with your colleagues. And I also always end up asking you to contact me if you have ideas for topics for future webcasts or particular speakers you're interested in hearing from. CSG would be glad to help facilitate those. So thank you very much. Thank you those of you who are on the call for joining us. And tune in on our next Tune In Tuesday.